So now we'll take a little bit of a shift into a panel discussion looking at predicting the future of precision health. And so you'll see a couple of familiar faces. So Zhenan Bao will be joining us, professor of chemical engineering and chair of this department as well. We'll also see Kenneth Mahaffey, professor of medicine and vice chair of clinical research. And we'll have Joseph DeSimone, who's the Sanjeev Sam Gambhir Professor of Translational Medicine and Professor of Chemical Engineering. So it's really a pleasure to have, such esteemed experts in these different areas with us today. And, thank you so much for joining us. Before I begin, I just want to remind everyone, please do use Slido and ask questions. I'm happy to continue to ask things, but, be great. I want to make sure everyone is getting addressed. So, take a look at the upper right corner of Slido and feel free to fire away. But yeah, absolutely. I'd like to, basically what we'll do is, we hit some interesting topics and, would be open to everyone. So feel free to chime in whenever you like. And I'll start us off with Ken, thinking about, large scale precision health clinical studies. What are some key mistakes you see investigators making when they try to deploy precision health methods at scale? And you've had a lot of experience with this, I think, with Google Baseline. What are some things, strategies maybe you use to kind of circumvent these? And obviously trying them is one, but it'd be great to hear your insights.
Yeah, that's a big topic, and we have learned a lot from Project Baseline, but also the Apple Heart Study and other programs. But Ryan, I do need to make one comment because I was quite remiss in my presentation that I did not acknowledge Gary Gold taking over the co-PI ship of Project Baseline Health Study when we had the change in leadership after Sam's passing last year. So I'm really looking forward to working with Gary, and I wanted to make sure people recognized his important role now in the project. Thanks. Yeah, I'm a simple cardiology trialist, and when I think about new technologies that are being developed, I think about them with this framework. When people come to me, one, does it actually measure what they think it measures? Number two, does it then actually measure what they think it measures in a more real world population with the disease of interest where it's going to be used? And then number two, when you take that technology that you now have confidence that it measures, when you integrate it into clinical care pathways and decision-making, does it actually help people and not hurt people? And so with that context, and it'd be great to hear the other panelists' thought process, because we're all going to be different, but that's the way I approach this technology development. And what you're asking is on the way on the right-hand side, when we deploy these at scale in a huge population, we've learned a couple of things. One is the initial uptake and enthusiasm by participants is tremendous, but the fall off in interest and adherence to protocols happens very quickly. And that if we don't continue to engage the participants in a meaningful way so they understand what we're doing, they're just going to leave the watch off. They're going to slip the sleep device out from under the bed. They're no longer going to put the patch on anymore. They're not going to go to a hub and transmit the data. So those are the first two things I would say. One, we have to figure out how to engage with participants more regularly and keep them excited about the technology.
Excellent. Any other comments from our other panelists?
Yeah, maybe I can add something. I think that's a really important message that Ken just brought up as someone who tries to develop wearables, had a little bit experience with also trying to commercialize one of the wearables that we developed in the group, which is for non-invasive continuous blood pressure monitoring. And we find it's especially challenging to really if go to the consumer market immediately. There are so many challenges, and people know once they know their normal number, then they probably just throw the wearable somewhere in their drawer and no longer need it. So eventually we talk to a lot of physicians and talk to a lot of potential users. And then eventually we decided to take a path to start from the neonatal intensive care unit. That's where there is really a critical need for a non-invasive continuous blood pressure monitoring device. And there's a strong clinic draw from the clinicians and from the interests of the patient. And then we're going to stay inside the hospital for a while for the product development of neonatal, then to adult in the hospital intensive care, and then outpatient care that's prescribed by the doctor. And then learn the kind of some of our colleagues said going to consumer product is going to the wild. So we will learn first and then eventually go to the wild later after we kind of address all the issues. So.
Great. Yeah, I think all those are really, really helpful tips for those, trying to work their way into this space or already underway. So thanks so much for that. I'm not gonna let Joe off the hook here. So now
I can just generally comment. I'm new to the field, but I think the points they're making raises the bar on the technology and sort of for the patient compliance. I'm here wearing my Aurora ring, and I've been wearing it for almost a couple of years now, pre-COVID, and I know the NBA used it in the bubble and all those things. And so when you have a easily compliant device that brings value, I think those just raise the bar on the technology and the implementation for it.
Excellent.
Ryan, I think the other important distinction that we need to emphasize from Zhenan is that one of the things that companies need to decide early on is, are they going to be a consumer product or are they going to be a medical product? And I think a lot of people don't understand the distinction. And then that causes them to go down pathways of development, particularly in terms of how data are collected, that may compromise their regulatory strategy if they want to end up with FDA regulated products or devices. And that's an important issue that needs to be thought through, because we heard the word consumer earlier on. I was using it in terms of medical care. And I do think that's a pathway of distinction that needs to be made very carefully, very early on.
Yeah, absolutely. Excellent point. Yeah, certainly will change the development course dramatically. And one question I also had for you, Joe, was, you've had a lot of experience with creating 3D printed devices, with your success with deploying carbon and, creating all these really interesting tools now at Stanford. Can they be personalized and distributed at a reasonable cost? Kind of to the point of, pulling back from deploying them, but kind of creating these devices?
Well, very much so. In fact, that's the use case that I think really drives a lot of value, because a digital printer doesn't care if it's the same file or a different file, and bespoke products are a huge opportunity. And you fold into that the fact that imaging is becoming free, right? Scanning technologies have gotten so ubiquitous and so powerful that you can really start tailoring things. And so, as Zhenan mentioned, we're spending a lot of time in the PICU as well, the Pediatric Intensive Care Unit, and excuse me, and nothing is more impactful than, being able to take an image and generate bespoke devices. And we have a number of examples in the oral cavity, right, in the mouth in particular, that ranges from things from the first FDA approved 3D printed dentures. And there's 30 million people that don't have dentures, they can't afford dentures, and being able to bring the ability of people to, having your teeth as an upward mobility issue, right, and being able to get a job and speak properly and eat properly. And my wife and I are just setting up a nonprofit in Durham, North Carolina, in partnership with the UNC Dental School to give people access to dentures, and those kinds of things are really important. But taking those breakthroughs in going from 8 chairside visits to 1 chairside visit, and you hear stories of people in remote parts of Alaska, having to have to go to a dentist 2 or 3 hours, 4 hours away, and and it's just prohibitive if you got to do that 8 times, and so give people that kind of breakthrough. But now taking that into the pediatric intensive care unit and helping babies with either CPAP masks or new oral devices and cleft palate, palate expanders to seal the palate, to delay surgery and improve outcomes. So many opportunities. And then you take the things that Zhenan's doing. My group is staring at all the beautiful work she's doing and thinking about how do we censor up, these devices to now collect data in a bespoke way that can really have us better understand, how babies are breathing and tissue remodeling in the neo-intensive care unit. So lots of opportunities there for sure.
Excellent. Yeah, and you bring up a good point of kind of, also thinking about different cohorts. So you mentioned, the children, there's also, mothers as well. Does anyone else have any plans to kind of utilize these cohorts either as part of a Stanford effort or project baseline? And what are some of the considerations, I guess, with, looking at, obviously, when we look at very early disease type detections or implementation, we're working with children and mothers sometimes. So it'd be great to get your perspectives. What are your thoughts, Ken?
So, obviously in Project Baseline, we're focused on cardiovascular prediction and prevention, and then oncology, specifically targeting lung, ovarian, and breast cancer being some of the most common cancers that contribute to substantial morbidity and mortality. So those are the areas of focus in Project Baseline Health Study. When I think about also, wearable and digital technologies, I think there's 2 approaches to developing them. One is in niche diseases, right? So in my world, it would be something like, we used LV non-compaction syndrome, not a very, very common disease, but a really important one. Mm-hmm. Or we think about developing technologies for very, very common diseases that have a huge societal burden of morbidity and mortality. So for example, hypertension or diabetes. And so those are the populations that when I talk to people, I try and, and they're looking for a use cases. Oliver Alami talked to us about in the biodesign model. You've got to decide what problem you're trying to solve rather than having a technology that you're trying to apply to a problem. I'm not sure I totally answered your question, but that's how at least my mind thinks about some of these things.
Yeah, I think that's super helpful. And yeah, it depends, I guess. So it's, it's great to hear your thought process. Yeah, I guess, I have another question that, what wearables or digital health approaches do you expect to kind of see, either that are promising or that are coming down the line kind of in the coming years?
Yeah, I think currently in research, there's a big trend of developing wearables that measure parameters that is specific, more specific to certain disease, instead of just use heart rate or number of steps that people have walked for everything and try to correlate with everything, but rather developing chemical and biochemical sensing from sweat, saliva, or subcutaneous fluids. And there's so much information one can extract, ranging from various hormones to cytokines. And if we were really able to measure these parameters accurately and continuously, then that really opens up great possibilities. But probably one at a time, as I mentioned in my last slide, is that for such kind of wearables, it's really very, very challenging, even though the sensors may have existed previously for measuring a certain biochemical very selectively, very specifically. But if you incorporate into wearables, even how you extract the body fluid reliably and how do you quantify it is a big challenge. And then coupled with body movement that can add a lot of artifacts and also drifting of the devices. So all of these are new challenges and also new opportunities for the community.
Yeah, absolutely. And, and speaking of the community, the other question that comes in, besides the technology aspect of it, is kind of the health and equity aspect of it. So it's already hard enough, I think, to deploy these, when we have an area of people that maybe have privilege. But what about, for the populations that maybe don't? What can we be doing now to try to address this kind of at a population level with some of the tools that we might have?
It's a really important question, Ryan, and we've always got to be thinking about the equity of these tools. As Zhenan said, there's a lot of need there for some of the interface with reliable testing or sampling, and we think a lot about interstitial fluid, and how does one access that and do that in a way that's cost effective. And I think anytime there's a cost effective element, it opens up equity and access, I think. And I think the 3D printing technologies, we're really interested in driving to very high resolution approaches so that you could have things like microneedles and other things that are sampling interstitial fluid. And, we have 5 times more volume of interstitial fluid than we do blood. And it's a really rich opportunity to be sampling. So that's sort of where I think about it. I mentioned the example with giving people access for dentures. That's important as well. But I think I have a little bit different focus than as a new person to find. We're really thinking about precision delivery. There's this mega trend that especially being in a radiology department, that people are getting really good at early detection when a lot of diseases are still local. But too many of our treatments are still systemic, and it lags behind the breakthroughs in imaging. And so the opportunities for now combining that information with new approaches for local precision delivery, I think, is a really great opportunity. And again, making those giving people access to those approaches will be important.
Absolutely. And yeah, I think that's a great segue into another question we had, which was looking how precision health and personalized medicine can complement each other. Maybe Zhenan, maybe you can start us off.
Mm-hmm. Yeah. So for precision health is more about understanding our health and nutrition, and that can allow us to prevent disease and also have potentially early detection. And so if we can put more emphasis on precision health versus after the disease already started, and then try to at that stage the cost to the treatment will be dramatically higher if it's already late stage. But of course, also the tools developed for precision health can also help to monitor the treatment effectiveness of the treatment, or maybe the disease after treatment might be coming back, and then we'll be able to know that early enough so that more effective methods can be implemented. So certainly the two are closely connected, and one can help the other and vice versa.
Yeah, Ryan, I'd pivot the discussion just a little bit, because we've really focused so far on kind of wearable and other technologies, but remember, a whole broad part of this space is digital, and that's data that we collect in hordes every single day during the clinical enterprise. And what a major focus needs to be on how we harness the power of the data we collect in EPIC and other EHRs to really drive the identification of disparities in healthcare and outcomes. That's critical. And then the second part of it is to use that data to conduct clinical research in much more efficient ways. And that's starting to happen. And one of the things people might want to get on their radar screen is that the American College of Cardiology in May of this year, they're going to present the adaptable trial results. I'm not involved with the program, but this is a trial that was a 15,000 patient trial funded by PCORI. And 90% or more of the data collection was done from the EHR in a consortium of large health systems, asking a very simple question: is 81 or 320 milligrams of aspirin better? But most of the data, all of the outcomes were collected through the EHR. That's another area we need to focus on digital transformation in terms of how we do research and integrate research into clinical care.
Yeah, excellent point. Great place to go, actually. And what I want to kind of a follow up to that is, what with the current COVID pandemic, there's a lot of unfortunate outcomes, obviously, from that, to say the least. But one of the things it has helped with is looking at remote monitoring, some of the reimbursement, kind of especially. And so, kind of to your point, Ken, what doors has that opened for us now that we have some additional, pathways forward where we can deploy some of these digital or medical devices or whatever it may be approaches because of this?
Yeah, I mean, the lessons that we've learned are just staggering in terms of the breadth and the potential impact. I mean, we now know that we can activate clinical research so much more quickly than we do usually, and we need to figure out systems in place so it doesn't take us 6 months to get a contract and budget approved and a protocol approved, and that will come. Number two is that we now see that in some areas like oncology, for example, where they have consortiums of sites that do research, we need to be much better organized as healthcare systems and research communities so that when we need to do large programs, we're not building the infrastructure and the silos for an individual trial, run the trial and then tear it down. We've got to have a national network by which we can basically leverage the infrastructure that is there to ask and answer a question much more efficiently. We've seen that. That's why a lot of the great work that came out of the UK early on is because they were organized. Now, they're very different in their healthcare system delivery and how they're organized, but those are some of the things that we've got to continue to discuss and not just go back to what we were doing when our lives return to how they were before.
Any other thoughts, either Zhenan or Joe?
I would just say, it's just interesting to think about it. The Zoom world we all live in now, and and triggered by COVID, obviously, and what that means for telemedicine and, technologies using, what kind of data are we capturing right now that could be very much related to our health and over time and some of those longitudinal studies. So I just think there's going to be new ways of thinking about data here that will come from this as well.
Yeah, Joe raises a good point, right? Our clinical enterprise transformed dramatically. So in the spring last year, about 80 to 90% of the clinic visits were being done by Zoom or the EHR Epic portal. And then as the pandemic evolved, we were down to about 40 or 50%. So I had clinic yesterday, and half of my patients, it was by telemedicine visit, and half of it was in person. And I'm talking to a bunch of scientists, and I'm a scientist, so this is a non-qualified survey. I asked people, why do they want to come in and see me? And the answers range from, well, I really thought it was important. I hadn't seen you in a while. Number two is, I really want you to listen to my heart and my lungs. Well, we don't know that there's much that I can actually learn from doing that. And then some of them were just tired of being holed up at home. And so we're going to have to figure out a workflow that makes sense for different cohorts of people. And I don't know quite where we're going to end up. Is it going to be 50-50 telemedicine? Is it going to be more? Is it going to be less? What is it going to be in an older population compared to a younger population, a sick population versus a healthy population? But I think how we do our work in the future will be very different in the clinical enterprise, that is.
Yeah, absolutely. It opens up a lot of new opportunities for developing kind of tools to enable telemedicine. And for my community, it's really now people are really energized to think about what are the things one can do to support that kind of future direction.
Well, we are unfortunately at time, but I think it's really great that, at the end you kind of, had a nice sum up of, also introducing the human element with the technology and making a nice balance for everyone in the future. So I really appreciate everyone's insights, and, thanks so much for sharing them with us today.